Welcome everybody. Thank you for coming to one of our weekly right now Vet Oracle live Facebook lives. We, as you may know, have been interviewing some experts in the field, and they've been helping us try to understand some pretty difficult but very clinical subjects. Tonight I have the pleasure of grilling Laurent Grossi, we'll come to him in a second, and Professor John Innes. As a way of introduction, John is a CVS Referrals Director right now, previously a professor at Liverpool, and well known in the field of orthopaedics, published over 85 peer-reviewed papers, several textbooks, book chapters. He previously chaired the BSAVA Scientific Committee and acted for RCVS in veterinary school accreditation. A leader in the field, and so we're very honoured to have him here. I know you're very busy, John. Thank you very much for that. And also important to point out to people that you are a supporter of the current world and European and soon to be English champions of football, that is Liverpool. So extremely honoured to have you here. And then there's Laurent.
Representing the country that won the World Cup recently.
I can't hear you, Laurent. I can't hear you. Anyway, so Laurent, as you know, is Moroccan. No, French. Obviously, everyone knows him very well. He is leading the internal teleneurology service for Vet Oracle and has been working for CVS since March 2019. Obviously, very well published in the field of neurology. Still regular speaker nationally, internationally, and helping push the field forward in many areas of neurology. So I'm thankful to have him also as a very good friend, despite the fact that he supports Arsenal. That is a problem, but and that he drinks non-alcoholic beer but still gets drunk. Also, tonight,
it's an alcoholic tonight.
Okay, all right. So, well, without further ado, if any of you don't know how we do this, then we have some pre-submitted questions that I will be asking both people tonight. Our question overall is, how do we differentiate forelimb lameness from a neurological cause of monoparesis? So two experts in this area can help us out, and we will ask them questions that have already been submitted. You are free to start typing away if you have some questions, and we'll ask those at the end. So forelimb lameness or monoparesis, otherwise titled, I can't find anything wrong with this dog, so I think it's yours. Or alternatively titled, it's not orthopaedic, it must be neurologic. So without further ado, my first question, and I think both of you can take this one, is what do you, how do you differentiate lameness and monoparesis? How do you use those terms?
Want me to go first, Laurent?
You're more than welcome.
Well, I mean, I guess obviously most lameness cases probably end up coming to an orthopaedic vet initially, and when we don't know what's wrong with it, we pass it on to you guys. But I suppose forelimb lameness, you know, as my old friend Don Hulse used to say, it's in the elbow joint until proven otherwise. So I guess most forelimb lameness does end up being a diagnosis of elbow issues. But we've always got to be wary of, you know, the zebra in the room, the unusual cause of forelimb lameness. And I guess neurological causes of forelimb lameness fall into that category. But, you know, it's always got to be there at the back of your mind that this may not be a common problem. This might be something unusual. And I guess, Laurent, you know, you would see forelimb lamenesses that us guys are struggling with, and we want your opinion on it. Would that be right?
Yeah, no, absolutely. And the issue is that, you know, sometimes you could have a monoparesis that look obviously neurological and is not neurological. And then you got the obvious lameness that you will think, oh, you look, you know, orthopedic, and actually is not orthopedic. And I think the point of this discussion tonight is to try to discuss together what are the red flags for you as an orthopedic to say, hold on a sec, I think, you know, there is a zebra, as you can say, and the same for us, you know, with monoparesis, when to think actually, you know, that's not neurological, but lameness. I think we had a video, John, we can put, and you may want to give some comment on that. It was a case you see now. He will work.
Might be a bit jumpy, but here's a dog that's got a severe forelimb lameness. And it's a short video, maybe we can play it again. But I guess the alarm bells start ringing for me when I can't find an obvious seat of pain within the limb. And if I'm struggling to find pain within the limb, then I'm thinking, well, I need to run my screening neuro test on this dog as well. That dog there particularly, raised alarm bells because of the severe muscle atrophy that's obvious around its scapula. And that sometimes is one of the things that triggers that alarm bell.
So will you say that all the orthopedic lameness are always associated with some form of pain? Or if the dog is not painful, can we be sure it's not orthopedic?
I think most lamenesses are associated with pain, but some are not. So, lameness is dysfunctional locomotor system, usually associated with pain, but sometimes it's mechanical. We do sometimes see mechanical lamenesses and not associated with pain, and then sometimes it's neurological. And that's when I'd start making sure I'd run those neuro tests that kind of help me decide.
Yeah. Which we're going to discuss. Discussing, monoparesis is obviously, the most commonly we suspect is a neurological problem. And monoparesis means that there is reduced voluntary movement. And if obviously, it gets worse, we then talk about monoplegia when there is no voluntary movement. And, from a neurologist point of view, we always obsess about trying to know where to look. If an animal is monoparetic, potentially the lesion could be in the neuromuscular system that supply, that forelimb. So it could be in the peripheral nerve, less likely junction because it would be unlikely to affect only one limb. Potentially muscle affecting one limb is always a possibility. That's what we call, lower motor neuron paresis. And typically this dog will have, or cat will have muscle atrophy, but tend to come very quickly. This muscle atrophy may be specific to the territory of a peripheral nerve. So, for example, if it's the radial nerve, it will be more the extensor system. So we got a pattern of atrophy that could point toward, a neurological cause and a specific nerve. But typically, this dog with monoparesis that are lower motor neuron, they have muscle atrophy. They tend to have sometimes difficulty supporting weight, sometimes difficulty withdrawing their limb, and they tend to have a short, stride on that limb. And that's where, they may overlap with the orthopedic cause, because typically with orthopedic lameness, you will have a shorter stride on the affected limb and a longer stride on the contralateral limb. But not to forget, sometimes the problem comes very slowly, and the monoparesis may be mild, and in this case, the lesion may be not peripheral, so neuromuscular, but maybe also affecting the central nervous system, and that could be, in the C62 spinal cord segment. It could be in the C1, C5 spinal cord segment. Very rarely, we may be dealing with a brainstem, localization on one side, but often, in this case, you expect to have over brainstem sign. So the animal may have a head tilt, it may have over cranial nerve issue. But aside from that, it's unlikely to be anywhere cranial to the brainstem or rostral to the brainstem. So one thing is sure is that if there is motor deficit, it has to be brainstem caudally. The only exception to that, you may have forebrain lesion causing hemi or monoparesis, but more often hemiparesis when they are very acute disease, and that is mostly cerebrovascular accident or potentially head trauma. So keep in mind, monoparesis in my mind could be in the limb, but it could be also spinal cord, potentially brainstem.
Yeah, it's a good point, and I think it's particularly those severe lameness cases. They can really mimic neurological disease, but they can just be a severe lameness. That dog we saw in the video there, I was concerned about neuro disease in that dog, but actually it ended up with a diagnosis of a septic elbow, a chronic septic elbow.
Yeah, so they could look very, very similar, definitely.
Yeah, absolutely. Yeah.
Well, so based on the fact that sometimes you can be more certain than others, what is your general diagnostic approach to these cases? I'm going to ask Laurent to start on this one.
Well, obviously, this is a neurology webinar, and we try to put everyone back, in the situation where they may be, seeing a suspected neurological case of lameness and monoparesis. I would say that my approach would be exactly the same as for any, neurological problem. And, that always start, is it actually neurological? There is a lot of crossover between disciplines. So, you got the dog or the cat that is blind in one eye. You're not going to rush to look at the brain, but you're going to look at the eye first. Same with, pupil abnormality. And with lameness or monoparesis, it is the same. Even with monoparesis, you could have a cat that is obviously monoparetic, but he may have, dislocated joint. He may have humeral fracture, and that's why he's not moving. Or he may have, any trauma to the limb itself without any neurological involvement. So it's really to focus on, ruling out neurological problem first, non-neurological problem first. And even so, orthopedic disease could affect your neurological exam. So an example will be when you test the proprioception, you may do the hopping response. If an animal has a very painful elbow, a very painful, shoulder, he is not going to hop normally on that limb. Potentially, when you do the paw positioning, if you don't take all the weight of this animal, he may not want to replace the paw because it's sore. So it's very important to rule out orthopedic cause first, because you may wrongly think you got neurological involvement when you test the postural reaction, as an example. And then John will describe a bit more, what does it do to examine a forelimb lameness. The next step after that, when I think it is neurological, I try to establish where is the lesion, like I've discussed. And to know, is it peripheral? Is it C62, C1, C5, brainstem? And I will not think of any disease until I've answered that question. There is absolutely no point to go fishing, doing a whole lot of tests until you know what you're looking for. Some diagnosis may be made by exclusion. And you can only be sure or make a diagnosis of exclusion when you're sure you're looking at the right place and you rule out any other mimic of a disease affecting, that portion of the nervous system. Otherwise, impossible to make, diagnosis of exclusion.
Yeah, it pains me to say it, Laurent, but I agree with everything you've said there. And it's, I guess as an orthopaedic specialist, when we're seeing lamenesses, we're expecting the vast majority of them to be an orthopedic cause, because common things are common. And orthopedic causes of lameness, I think, are obviously more common than neurologic or monoparesis. So I guess we work very hard to systematically, examine the limb from distal to proximal, looking for pain, swelling, anything that pain on manipulation, anything that gives us a hint there might be a focus of pain within that limb that then we can focus on it further for diagnostics. But you're absolutely right that a bit like you said with the eye, you look at the eye first. So we're going to look at the limb first and look for causes of pain. And if we can't find that, then absolutely do exactly what you said, which is to look for neurologic cause and look in those different locations that could be causing that. Yeah.
John, in terms of pattern recognition, maybe it'll be important for everyone listening. Circumstance of the lameness, post-exercise, during exercise, the type of ground. Is it soft ground? Is it more gravel? What can you indicate in terms of, is it orthopedic, and what kind of orthopedic problem could it be?
Yeah, so I think there are certain key questions for clients that can give you a hint that it might be orthopedic rather than neurologic. So, if inactivity stiffness, I think, is a really good clue that it's probably a joint-related problem. So if an animal is stiff on the limb after a lie down, particularly following exercise, that generally is joint disease. Not always, but but generally. And I think that can give you a good hint. An exercise that gets worse with exercise might be more typically muscular or tendinous in nature. And I guess maybe some neurological causes of lameness get worse. I guess I would put a caveat on the inactivity stiffness. And I sometimes think that disc disease can cause an inactivity stiffness. Maybe not so much in the thoracic limb, but certainly in the pelvic limb.
But even in the thoracic limb, we'll see an example at the end of a far lateral a far lateral disc extrusion. And typically this dog, after laying down, when they stand up, they may be very lame, very, very lame. Yeah. But we will come back to that, of course.
And not to get ahead of ourselves, but do either of you ever use medication in a therapeutic trial approach to see where you would go? In neurology, sometimes it's rare, but sometimes we don't know what's going on with a case, and we might use medication as a therapeutic trial to try and help us. So I was kind of throwing this out to both of you, particularly John. Do you use medication in any way to help you shape a diagnosis?
That's an interesting question, Simon. I have to say probably that would be a rare thing for me, on the basis that there are lots of orthopaedic causes of lameness that may or may not respond to medication. We've got a sort of limited medical armory in orthopaedics, and if the response is so variable in any case, it doesn't really give us a great clue. But I don't know, what would be an example for you guys of doing that?
I think, Simon, you may be thinking in horses where they may use localized and no?
I never think about horses, Laurent. No.
I do sometimes use local anesthetic into joints.
That's a good point. That's a good point. I actually wasn't thinking about that, but that's a good point. I'm actually thinking from my own practice when I have no idea what's going on. I sometimes wonder whether if we use non-steroidals and we get a great response, am I pushed more towards an orthopedic versus a neurologic? No evidence for that, completely anecdotal. That's my quackery. Just wanting to know if that's something that either of you would do in this situation.
I think it would make sense from a neurology point of view, because I guess neurogenic pain tends not to respond very well to non-steroidals, but joint pain can. On the other hand, joint pain sometimes doesn't respond at all to steroids, particularly elbow pain. I think sometimes chronic elbow disease sometimes doesn't respond. I could see that from your point of view. That could give you some useful insight. Yeah.
Very polite answer to me there, John. Thanks very much. I'll go back to my...
The Frenchman wouldn't get the same sort of politeness. Only Liverpool fans get that.
Glove off with it.
Yeah, thank you. All right, so next question. This one's for John. What are the common causes of forelimb lameness, and how would age and breed influence your differential list?
Yeah, well, I mean, obviously we've only got a few minutes to discuss, but I mentioned already that elbow disease is a really common cause of forelimb lameness, and there are particular breeds, of course, that are very prone to elbow disease. So young dogs, certain pedigree breeds such as Labradors, Rottweilers, those that are very prone to medial coronoid disease or elbow dysplasia. So in those breeds, we look very hard at the elbow, because 95+% of dogs of those breeds and that age bracket coming in will have elbow disease. But I guess we've got to also be keep in the back of our minds that there might be clinically silent elbow disease, and there might be something else going on. So you've always got to be open-minded, I think. And depending on your patient population, if you're seeing a lot of working dogs or agility dogs, then shoulder lameness can be quite common in adult dogs too. But it does depend very much on your local breed population, I would think.
Right. And for Laurent, with monoparesis, where do you start? Where are you beginning with the case? I mean, you've said a little bit about this, but just to expand on it.
Yeah. I mean, in terms of monoparesis, as I say, it all depends. If I've got a dog or a cat that is severely monoparetic to the point of having very little voluntary movement, it's very likely that the problem is within the limb itself. So that could be obviously the brachial plexus, it could be the peripheral nerve, or potentially the muscle. The tricky case are the case where there is mild monoparesis, because potentially we could have a lesion, that is not a peripheral lesion, but more a central lesion. So I need to answer that question: where should I look? And to do that, you probably know I'm not a big fan of doing a full neurological exam. I think anyone that I work with me or follow the lecture will know that I tend to do a targeted neurological exam, and I tend to use a neurological exam like a toolbox to fix a problem. So depending on the problem, I may get different tool. So for an animal that is monoparetic, the next tool I'm going to use is the gait. So I'm going to make the animal walk, potentially straight line, a different pace, sharp turn, and that will help me to look at any of the other limbs. So I tend to blank out the monoparetic limb to assess the other limb to see are they normal or not. And then after that, if I don't have clear answer about the other limb, I'm going to challenge each limb individually by testing the postural reaction. And as I say, it's important to do that after ruling out any source of orthopedic issue, either that there is reduced joint movement or increased joint movement or pain, because they could interfere with the testing of the hopping or the paw positioning. And really the aim of doing this postural reaction where we test the proprioception is not if you got a dog that is monoparetic on the left limb, there is no point to turn the paw there. We know that this paw is affected, but I want to check all the other three limbs to see if I can detect some subtle abnormality, but were not present at the gate. That's really why we do the postural reaction. Because if we are in this situation where other limbs are affected, let's say that the ipsilateral hind limb is affected, then it's definitely not a peripheral problem. And the problem could be in the neck, on the ipsilateral side, potentially brainstem. If the opposite forelimb is affected, but the hind limb are normal, then we may be looking at a bilateral brachial plexus, lesion. So, I go with the gait, the postural reaction, and then the next step after that, if, I identified that it is central, meaning the spinal cord in the neck on one side, I'm going to assess, the spinal reflex. And for me, I go back to the basic what a limb can do. A limb can either extend or flex. So I'm going to test the flexor system and the extensor system. So the extensor system, I lift the opposite limb to see if the dog can support the weight against gravity. I'm going to pay attention especially to the elbow to make sure that he can keep the elbow in extension and not sink on this elbow, keep the toe and extend it as well. So I test the extensor system, which is mostly, the radial nerve. And I'm also going to pay attention to the other, part of the story, the flexor system. And it's something that I tend to bang on all the time. Most people do not do the flexor reflex properly. When you do the flexor reflex, just pinching like that is not enough. You pinch, you want all the joint to be totally flexed. And when you've done that, you haven't tested anything. The joints are all flexed, then you start pulling the limb to see the strength there. And until you've done that, you haven't tested the flexor system. So that helped me to know, is it more likely if both extensor flexor system are normal, that tell me it's more likely cranial to C6. If they are abnormal, it helped me to know, are we dealing more with a cranial plexus or caudal plexus, depending whether the flexor, the extensor system is affected. If the reflex are abnormal, then I go a little bit deeper by looking at the dermatome. So I look if there's any decreased sensation. And you will find, this diagram in many books that tell you for each nerve, there is a defined portion of the skin that you can, test in terms of, sensation. So that's the way I tend to approach it in a very logical, like an algorithm to look at where is the lesion. For an animal that is, lame, this is a little bit more tricky. So we talk about the paretic. With the lame dog, if an orthopedic surgeon asks me to look at the dog, they haven't found any orthopedic issue, I'm going to do exactly the same, but I'm also going to pay attention, especially to two other reflexes. One is the cutaneous truncal reflex, and the other one is looking at the pupil size. So why the cutaneous truncal reflex? You got a diagram there. I test the cutaneous sensation in the lumbar spine because when you stimulate there, the message go inside the spinal cord up to C7-T1 spinal cord segment. Then you got the lateral cutaneous nerve that will contract the cutaneous truncal muscle. And if you got a brachial plexus lesion, avulsion or tumor, you may actually lose the cutaneous truncal reflex on one side. And sometimes with a dog that is lame, is not painful, the orthopedic surgeon have looked at the dog, they can't find any orthopedic cause. The only thing that could tell me it is actually neurological could be, if I've got absence of cutaneous truncal on one side. The other thing to look.
I agree with that, Laurent. I mean, I can think of a handful of dogs over the years that I've seen where that has been the key clinical finding, that paniculus reflex. And it's a really useful test to bring in these cases.
And it's, as I say, it can sometimes be the only one. And, hindsight is a beautiful thing. When you're in referral center, you may see the dog after he's been moved from pillar to post, from one clinician to another one, and it's obvious it is neurological. But initially, they could be really difficult. The other test I'm going to look is I'm going to check the pupil size. And especially in dim light, I'm going to ensure that the pupils are symmetrical. An example here is a cat that is monoparetic. And if you look carefully, this cat has anisocoria, and the left pupil is smaller than the right. And when we put this cat in the dark or in dim light, we could see that the left pupil didn't dilate. So, just brief explanation why that. The sympathetic supply to the eye is the most ridiculous pathway you can find. I think it must have been designed by an orthopedic surgeon or something like that. You will think that the quickest way to go from the brain to the eye will be the straight way. But being an orthopedic surgeon, you try to make complex things when they are actually simple. So you decide to go down the spinal cord up to T1, T3, then leave the spinal cord with the brachial plexus to then go back to the eye. As I say, if you want to waste time, that's a perfect way. But it's also a good lesson is that sometimes this anisocoria could be the only sign to tell you that this, acute lameness that we can't pinpoint, is it orthopedic or not? If I got anisocoria there, or if I got cutaneous truncal deficit on one side, that tell me we're dealing with, a neurological problem.
Yes, another good point, Laurent. In fact, I had a case recently where I was doing a teleconsult, and so I got the clients to take a picture of the dog with their phone in a darkened room with a flash on from about a meter away with the dog looking at them, so I could see the pupil size. So it's something you can check out even on a teleconsult if you give the clients some instructions, but really important, yeah.
Yeah, good stuff. Well, again, Laurent, I tried to shut you up, but I can't. Here we go. So there's another question for you. Before you start a war with orthopaedics, which we none of us want, just clarify, John, we don't want that, right?
It's okay. We'll win anyway.
Oh, God, here we go. It comes out in the end. All right. So what do you consider are the common causes then of a forelimb monoparesis?
Yeah, so I'm going to go very quickly, so then John can expand a little bit more. Before I do that, this is the way my brain is working. So we start the monoparesis. Are the other limb affected? Yes or no? And then we go into localizing. But you can find it, in many textbooks. Another thing I should add is, in this dog, where it's not very clear if it's neurological or not, electromyography can be really useful. Again, if you work with me, I absolutely hate anything to do with electrophysiology. I think very often it's a total waste of my time doing that. But with a monoparetic or lameness dog, when I've got muscle wastage on a lame dog, only finding abnormal spontaneous electrical activity will tell me it's neurological. So if you got a dog that has been lame for 2 months he's got muscle wastage and the EMG is totally normal, I will say go back to the drawing board for the orthopedic surgeon, because it is probably orthopedic, if it's going on for that long. In terms of common cause, brachial plexus trauma is definitely, common cause of monoparesis. You may or may not have the history telling you there's been a trauma, especially with cats. They may come back like that. In dog, usually the history will tell us. But if I assess a dog with brachial plexus trauma or a cat, I try to know, is it more the cranial or caudal plexus? The caudal plexus is probably the most important because it's the weight-bearing system of the limb. It controls the radial nerve. And in terms of recovery, in terms of what we can do, possibly surgically, and John may, tell us about carpal arthrodesis, to treat this dog and so on. If I've got no weight-bearing ability, then surgery is out of the question, in this animal. Brachial plexus trauma, with regard to diagnosis, as I said, most of the time is a clinical diagnosis, if the history is consistent with that. I pay attention to, weight-bearing, so radial nerve function. I pay attention to nociception distal to the elbow, both of them, lack of extensor tone, lack of nociception distal to the elbow, carry a, guarded prognosis. And I will say to the owner, give it a couple of months, lot of physio, but if after 2 months, it's still the status quo, I would say that probably the end. Some people will do electrophysiology for that. It's been described that it can be a prognostic indicator, measuring, the nerve conduction velocity. It's not something I personally do. Interestingly, in terms of imaging, CT myelogram can be useful in showing, signs that could be consistent with avulsion. So, do a myelogram, you do a CT, then you inject contrast in the cisterna magna. If you got leakage of contrast, it may indicate that you got avulsion, of the nerve root. And in terms of MRI, again, it's not something I will advise routinely to do, because what you want to know, what the owner want to know, is the animal going to recover or not? And I think the sensitivity of the MRI, even if it shows some abnormality, will not be good enough to tell you if you got neuropraxia or if you got complete severance, of the nerve root. So some people have described in human giving intrathecal injection. I think there's one report in veterinary medicine. I think it's quite, clever things. I never try, but maybe, it'd be something to try more often in this case. Brachial plexus tumor, that's, the one that very often overlap with orthopedic surgeon. This dog usually initially are lame, and they've been examined by the orthopedic surgeon. They may have done further tests, find nothing, and very often, at the end of the road, you end up finding, a brachial plexus mass. More often in dog, it's a peripheral nerve sheath tumor. In cat, more often lymphoma. But, things can sometimes look very similar, especially with hypertrophic neuritis. An example here of a cat with a bilateral brachial plexus neuritis. And it looked very similar to a brachial plexus tumor, and it could affect, only one side. Unfortunately, prognosis, is no better, I would say. Even if you got hypertrophic neuritis, you may have temporary improvement with steroids, but it's not going to go away in my experience. And again, they are very, very rare. The last one, in terms of what I see commonly as cause of monoparesis or neurological lameness, is the lateralized disc extrusion. So this could be in the canal, and in that case, we talk about lateral extrusion. It can be in the foramen, and we talk about foraminal disc extrusion, or it can be like on this slide, outside of the foramen, and that's what we describe as far lateral disc extrusion. And that's the one that very often mimic orthopedic disease. What will tell me is more likely neurological? Well, again, this dog will have neck pain on one side, and the best way to assess that, when they're laying down, all the muscle relax. That's where you need to palpate, this neck and try to elicit pain. They tend to be painful, especially when you move the neck on one side, and they typically have this nerve root, signature.
Right, thank you very much for that. Now, I've actually finally got a question for you, John.
Just a comment there. I mean, even I've used EMG, Laurent, in these cases. So even an orthopedic surgeon can do that spontaneous needle EMG, and it's really useful.
Yeah, and that's all I can do, to be honest. Everything else, I have absolutely no interest in the EMG. Our college is, a lot of people are very interested by that, but I prefer to leave them to play with it.
Yeah, I guess I've in a couple of cases in my career where I've had radial nerve involvement, but it's obviously been partial. I've used it to map out the denervation and then see if those dog. I think of a dog and a cat actually, where I've done this, and then map them out. They might be candidates for tendon transfer. So you know, for instance, the triceps isn't working, we can transfer the biceps tendon onto the triceps tendon. It'll the musculocutaneous will relearn to become an extensor of the elbow. So that's helped a couple of cases I've seen over the years.
You want to come back maybe for everyone, what will be your ideal case of brachial plexus trauma where you will consider tendon transplant?
Well, it's going to be those very rare cases where you've got enough radial nerve function to support weight, and I think you mentioned that already, and it's got to be partial. So yeah, a case like that where you've got triceps involved, but the carpal extensors are okay. I mean, you can look at carpal arthrodesis as well. I've never done that. I just always worry about the distal limb getting damaged in those dogs where they haven't got the sensation to place the paw correctly.
So John, there is a question about whether you have a preference between CT or arthroscopy for diagnosis. But I want to expand it a little bit and just throw in radiographs and MRI. What sort of imaging do you prefer? How do you use imaging to sort of logically work up your lameness case?
Are you talking about the whole forelimb here, or?
Yeah. Obviously you've narrowed down where maybe your concern is, but.
Yeah. Well, I think it varies. Unfortunately, it's going to be not an easy answer. It varies probably depending on what's top of my differential list and where the location is. So for the elbow, which is probably the most common cause of forelimb lameness, CT is really useful, but I don't consider it 100%. So CT is really useful, and because CT is so quick to do, I would generally just scan the whole forelimb anyway. But clearly, it's very good at picking up coronoid lesions. I guess arthroscopy is still a powerful diagnostic tool in the elbow, and for clients that are on a budget, I might say, well, let's if I really suspect the elbow, I might say, well, let's skip the CT if they're struggling in a budgetary sense, because with arthroscopy we can actually do something about the lesion if we see it, and you will pick up most coronoid lesions with arthroscopy. You get the occasional one where the cartilage hasn't fragmented but the subchondral bone has, and you might miss those on arthroscopy, but equally you can miss some fragments on CT if they're not displaced at all, and you can't see the fissure. And then shoulder, I think arthroscopy probably is my priority, but MRI can be useful too. I think with shoulder lameness, CT is less useful because it's often in adult dogs at least. It's a soft tissue, tends to be soft tissue problems around the shoulder. But MRI is great. It's just expensive to do, obviously.
Yeah.
Quite often you need to follow it up with an arthroscopy anyway.
Yeah. All right. Well, thank you very much for that. I know Laurent has probably been getting some questions from the audience, so I'm going to throw it back to him right now. Before I do that, I wanted to say thank you very much, John, for giving up your time. I realise that you're on vacation this week, and you've given up a part of an evening with your family to.
What better thing could you do on your vacation than spend half an hour with Laurent and Simon?
I agree, but other people may be dubious about that. But thank you very much for saying that as well. But thanks very much for giving up your time. I really appreciate it. It's really helpful to have sort of cross-specialty discussions about some of our major problems. So thanks for that. And I'm going to throw it back to Laurent, who's gone.
Yeah, there's not many questions, and obviously we've gone a bit over time. There's a question for John. Do you always do joint tap, and when will be your indication on a forelimb lameness to do joint tap?
Yeah, well, do I always do a joint tap? No, I'd be a liar if I said that. You know, I think generally, you know, imaging is the, you know, after a clinical exam, imaging is the next step, whether that be radiographs or CT. You know, I'm a big fan of doing joint taps and synovial fluid analysis, and you know, I've got a long sermon on synovial fluid analysis and its usefulness. But I don't always do it, but if there's any suspicion of inflammatory joint disease, whether that be infection or immune-mediated disease, then yeah, absolutely, I would do joint taps. That video you showed earlier, Laurent, of that very lame dog, I wasn't sure whether it was neurologic or orthopaedic. It had a joint tap of its elbow because it had arthritis of its elbow. But its lameness was so severe, I was worried about something else going on. And it had a septic elbow. So yeah, if things don't quite add up, definitely do a joint tap. Yeah.
And on the video, I'm sure you played the video. I'm sure a lot of people will have said it's neurological. He is monoparetic. He's got severe, you know, muscle wastage, and it's easy to think he's neuro. You know, there is another question for you. What is your thought on using nuclear scintigraphy in the case where it's difficult to identify the source?
Yeah, that's a good question. You know, I did a lot of scintigraphy during my PhD, and I have used scintigraphy for occult forelimb lameness, and it has, back then at least, it was useful, but that was back in the days before CT and MRI were widely available. So I guess it's, you know, it may be very occasionally useful. But it's only going to pick up lamenesses that are associated with increased bone turnover. So again, it's not a panacea for detecting where a lameness is being caused. And I mean, I guess its availability these days, you know, is pretty limited unless you happen to be linked to an equine clinic. But yeah, I've certainly used it.
Very good. I think we're going to draw to a close. Obviously, we've gone slightly over time. I will leave Simon to give the last word. I have to thank everyone. I always ask all the participants where they come from. We've got people from as far as Argentina to Taiwan, which is quite amazing, passing by India. Having all people from all over the world is really you know, a pleasure, and we're really grateful for everyone. But I will leave Simon to close this meeting, and thanks a lot, John, for joining us.
No, you're welcome, and it's nice to, as I say, see all those people from all around the world. It's great that they join your weekly Vet Oracle Facebook Live. Yeah,
well, thank you again, John. Thank you, much appreciated, and thank you, Laurent, as well for your time and for answering those questions. Thank you, everybody, for turning up. You obviously can watch this again to your heart's content if you click on the link that will be posted on the site. Next week, we have our final lockdown quarantine Vet Oracle interview. Dr. Fred Winninger going to be talking about 3D printing, how it helping with surgery, particularly with drill guides. So join us at the same time next week for that. Without further ado, thanks to everyone. We will now close this down. Thank you.